Good evening, Sushil sir.
Good evening. Am I audible?
Yes, sir.
Yeah, yeah.
Good evening, sir. Dr. Sushil, good evening.
Good evening.
Good evening. So, sir, we just wanted to check once.
Mm-hmm.
You'll be giving the context setting for the evening today and followed by your session. So, you want the team to introduce your talk's title as well, or you'll be taking over continuously after, I mean, giving your context in introduction?
You can start the introduction and then I'll take over from there.
Perfect. Sounds good. Okay. Sapna will take care. Yeah. Thank
Yeah,
you very much, sir.
thank you.
Thanks.
Thank you.
Sir, can we start by 7 p.m. now?
Uh, we can wait for another couple of minutes for all panelists to join, maybe.
Okay, sir. Yes, sir. Good evening, Joe, sir.
Good evening. Good.
Hi, Joe. How are you?
Oh, fine, boss.
Yeah, yeah. Nice, nice. Okay. I think we can start with the introduction.
Okay, sir. Good evening, everyone. On behalf of the International Association for Integrated Oncology, IAIO, I warmly welcome you to all today's insightful webinar on CNS cancers. My name is Sapna Nevar and I am your host for today's evening. Our focus today is gliomas in 2026 translating molecular insights into clinical practice. We have distinguished panel of experts with us to explore the latest developments in the rapidly evolving field. To begin, it's my honor to introduce our program director, Dr. Sushil Kumar Yashalla. He is the consultant medical oncologist at the American Oncology Institute in Raipur. He will be leading our first session and moderating our panel discussion later this evening. To begin, we welcome uh, our program director for opening remarks. Over to you, sir.
Thank you for a very warm introduction, Sapna. Today we'll be discussing on CNS cancers, and as you know, uh, gliomas are not the same 10 years back. A lot of things have changed, and we need to understand these molecular insights, latest updates, and then translate that knowledge into the clinical practice. So, that is the main intention. So, in the first session, where I'll be discussing on the evolution of CNS classification, how the CNS tumors were classified a century ago, and then slowly build upon that knowledge into the current practice, followed by two very real uh, case scenarios, and both are very interesting, but my favorite is the case one. You will be seeing soon why case one is very interesting, which I recently came across. We'll be having a wonderful discussion. I promise that, and you'll be uh, uh, taking lot of take-home messages, and hopefully you'll apply that to your clinical practice. And we have Sapna. Can you introduce our esteemed panelists too, or you want to introduce later?
Sir, I can introduce later?
Yes, sure.
Yes, sir.
So,
Okay,
shall
thank you.
we go ahead with the first session?
Yes, sir.
Okay, okay. So, let me share the slides.
Sure, sir.
Are my slides visible?
No, yes, sir, visible. It's open.
Yeah, it's opening. Okay. Thing. There is some issue with the slides. Okay. So, can you see my full slides?
Yes, sir, we can see your screen, but slides are not open.
Not open. Okay. So
Yes.
again, let me try. Is it okay now, or still you are unable to see the slides? I mean, full screen.
Yes, a full screen we can see.
Okay. So slides are visible and it's full screen, right?
Yes, sir. But
Okay.
slides is not open, sir. Your PPT slide is not opened.
So
Oh,
we can only see the folder right now, downloads
okay.
folder. Maybe you can reshare once again. Stop share and then maybe you can
I'll
reshare.
do that. I'll do that. Okay. Can you see now?
Yes, sir.
Okay. Can you see the full slides? Full
Yes, sir.
screen?
Yes, sir.
Okay. So let me uh, go through this topic, start the topic. So today we'll be discussing on the therapeutic impact of molecular testing in CNS tumors. This class will be, wait a minute, yeah. The flow of presentation for this would be in two parts. In the first part, we'll be discussing on introduction, background evolution, molecular classification of markers, and what are the major changes in WHO CNS 5 2021 update. Followed by, we'll be discussing on the therapeutic impact, challenges, future directions, and summarize everything. So the incidence of CNS tumors in India is in the 14th place, whereas in the worldwide it is 19th place. Not very common tumor. It is not even in the top 10. With regard to the mortality, again, it is not in the top 10. It's 11th and 12th position. But why we need to discuss, though it's not very common tumor, thing is that a lot of updates have come recently, and we need to be aware of these updates so that we can translate into our clinical practice. All the brain tumors, so tumors, it can be malignant, it can be non-malignant, and out of all the brain tumors, malignant tumors are only 30%. And majority of these malignant tumors are glioblastoma, or you can say more than 75 to 80% are gliomas, and rest of the 20 to 25% are other tumors. And if you look at the epidemiology and survival of the brain and other CNS tumors, we can see gliomas have kind of poor prognosis compared to other uh, tumors of the brain like meningiomas or other non-malignant tumors. And so by this time, you understood that CNS tumors are very heterogeneous group, and survival outcomes depends on histological type, grade, biomarkers, other patient-related factors like age, performance status, and again tumor-related factors like which side the tumor origin, like if it is in the brainstem, we know it is poor prognosis tumors. The size, if it is larger in size, um, uh, there can be issues, and also shape. So he's these are the Dr. Cushing, who has done extensive work around a century back on the brain tumors. What he did is he operated upon the tumors and categorized histologically into uh, very kind of primitive classification. So it's a Bailey and the classification of brain tumor. This is the first anyone has attempted the brain tumor classification. There you can see majorly he divided into three types: pineoblastoma, neuroepithelioma, medulloblastoma, and other neuroblast tumors. And in the neuroepithelioma, you can see the glioblastoma multiforme. So it's kind of very primitive classification, and the modern classification is built upon this classification. So this classification was around 19 uh, uh, during the World War period, and after that in 1976 there was the first WHO working group. They met in Europe, and a lot of eminent neurologists, neurophysicians, and neuropathologists have come together and attempted the what we call as the first WHO classification of CNS tumors, and it was in 1976. And later on, a lot of modifications occur every time, improving upon the previous one. Like in 1979, they have included the histological typing of tumors. In 1993, it was IHC was included for the first time. In the 2000, they have included the clinical signs, symptoms, imaging, and prognosis. In the 2017, they have included the new classification of cranial and paraspinal. Now, so every time they have attempted to build upon the previous one, improving further. The latest was in the 2016, followed by 2021. And in 2016, for the first time, they have included both the morphological as well as genetic characteristics. Till now, it was mainly based on the histopathology and IHC till 2007. But in the 2016, for the first time, they have combined both the morphology as well as the genetic characteristics, and that was the turning point. There was shift from histology to integrated diagnosis based on the histology and molecular markers. So what are those molecular markers? It was IDH mutation status, chromosome 1p19 co-deletions, as well as in the diffuse midline glioma, that is especially in the pediatric gliomas, it was H3K27M mutation, as well as in the ependymoma, it was RELA fusion. So overall, what you understand is that they have tried to include the molecular markers in the 2016 classification. So initially, it was mainly histological classification, but later on we build upon the layer 4, that is molecular information. So now whenever any pathologist gives us a diagnosis in the pathology report, it has to be final integrated diagnosis. So layer 2, first you look at the histology, then you grade it either grade 1, grade 2, and then you do the glioma panel, you include the molecular information, and then give the final integrated diagnosis. And that's how it is now. Previously, you can see they have given the specific example that though in the layer 2, it was infiltrating glioma with oligodendroglial features, but it was WHO grade 3. And in the layer 4, there is loss of both 1p19q loss, and finally, the integrated diagnosis is anaplastic oligodendroglioma, because WHO grade 3 usually tells us it's astrocytoma, but in the layer 4, there is correlation of 1p and 19q, and that points towards it oligodendroglioma. Hence, the final integrated diagnosis is oligodendroglioma rather than astrocytoma. So that's what it is. WHO grade 2 and grade 3 oligodendroglioma, oligoastrocytoma, diffuse astrocytoma. That was in the WHO 2007. But now it is clear cut. It is either oligodendroglioma or it is astrocytoma. Pathologist cannot give the confusing diagnosis as oligoastrocytoma. There is no such terminology in 2000, at least let's say after 2016. So beyond 2016, there is a recent update in the 2021, and that is the WHO CNS 5. And what are the major changes? There have been changes in the taxonomy, nomenclature, grading. They have included two specific entities like not otherwise specified as well as not elsewhere classified. And there are also specific changes within the tumor groups. There is separation of adult and pediatric gliomas for the first time, including the molecular characteristics. Added 14 newly recognized gliomas and glioneural tumors and 8 new other tumors. So there are a lot of changes happened between WHO CNS 4 in 2016 versus WHO 2000, WHO CNS 5 2021. And I have no idea why they have changed from Roman numerals to Arabic. Now you cannot write the Roman numerals. You have to use the Arabic while mentioning in the report. I don't know why that is, but that is what it is. And as you can see, they have clearly differentiated the pediatric as well as adult gliomas, and based on the mutations. Like in the pediatric, most common, it is histone H3, RAS, MUPK, MAPK pathway. In the adult, it is IDH mutation, 1p19q co-deletion. So again, you can see here extensive, they have totally differentiated between the adult as well as pediatric high grade versus low grade. So in this, you can see previously, if you look at the top left, if it is WHO grade 2 diffuse astrocytoma IDH mutant, it is now classified as astrocytoma IDH mutant WHO grade 2. So there are a lot of changes happen. Grade 3s have been shifted to grade 2s just because it is 1p19q co-deletion, and grade 2 if it is non-coagulated and if it is ATRX retained, then they have been reclassified into astrocytoma. So that reclassification has happened. So here you can see the clear differentiation where, uh, yeah, excuse me. So here you can see the clear differentiation between the 2016 as well as 2021. In the 2016, it was histology, IDH status, histological grade. And molecular profiling, it is just 1p19q co-deletion as well as non-deleted. But in 2021, they have further categorized into uh, ATRX loss, whether ATRX is retained or lost, and further, they have classified into CD, KN, 2AB, non-deleted or deleted. And based on that, again, we need to classify as grade 2 or grade 3. Again, in the IDH wild type, WHO grade 2, grade 3, it is diffuse astrocytoma. You treat it like a IDH wild type. And if it is WHO grade 4, obviously you need to treat it like a glioblastoma. And these are the cap recommendations, and whatever the CNS 5 have been reinforced the same thing, cap are agreeing. So I'll not get into the details, but they have given recommendations whether what are the molecular testings to be done whenever a patient lands up to the OPD. So it is IDH, ATRX, 1p19q. So these are strong recommendations. You can see strong recommendation. Again, TP53, it is conditional recommendation. So you need to be aware of this so that now we can be very choosy about our doing the molecular markers. Again, they have given what is the tumor type and what are the genes involved in particular tumors. So if you see the oligodendroglioma, it is IDH1, IDH2 mutated and 1p19q co-deleted, whereas astrocytoma, it is IDH1, 2 mutated, but it is ATRX retained. So that's how we can differentiate in terms of molecular characteristics. So now that we have an idea of the basic background on the evolution as well as the latest update, now how does this impact our management? So what is the therapeutic impact? So everybody knows it was uh, around 2 decades ago, Roger Stoop. So we popularly call it as Stoop protocol. Uh, it's a landmark trial, and usually in the glioblastoma multiforme, we give concurrent radiation along with the concurrent temozolomide, followed by maintenance temozolomide for 1 year. 2 decades later, so this paper was published in 2005. Even after 2 decades, still this is the standard of treatment. There is no change in treatment for more than 2 decades. If you look at the other sites like lung, breast, there is rapid evolution. Whatever we treated 5 years back may not reflect now. A lot of changes happens every 6 months, every 1 year we need to get updated. But how come glioblastoma, Mr. Roger Stoop has given us a standard of care, and still it is valid even after 2 decades. Now we'll see the reasons for that. Thing is that one of the major reason is the physiological blood-brain barrier. 98% of the FDA approved drugs do not penetrate the blood-brain barrier. That whatever the drugs we use, usually 98%. I'm not telling about only oncology drug. Any drug, 98% of the drugs do not penetrate the BBB. And this limits the therapy for all CNS related disease. And molecules more than 400 to 600 Daltons will not cross. For example, temozolomide, it is just 194 Daltons. Hence, it is able to cross the blood-brain barrier. Hence, we are able to use it in the GBM. Rituximab, let's say it's 145 kilodaltons, and it's just 0.1% of the IV dose concentrate into the CNS. Mainly because drugs are pumped. Even if these drugs enter into the CNS, they are immediately pumped out of the brain as a part of physiological protective mechanism. Now, next reason is intratumoral heterogeneity, and or not intratumoral heterogeneity. I can say that here we can see there is a tumor, and that is a tumor reflecting in the gross specimen as well as in the MRI. But if you look at the microscopically, you can see these tumor cells are spread into larger, diffused into the almost entire brain, you can see. So the focus of the tumor is here, but it is diffused into various parts of the brain. So even if a surgeon resects the tumor, and even if a radiation oncologist sterilizes this part in the post-op bed, still you can see few cells in the elsewhere. So that will, the treatment may not be adequate, and these cells act as you can say the sleeper cells, and then helps the in the tumor recurrence. The next so hence, am I audible? Hello?
Yes, sir.
Yeah. So hence the scientists have researched on this, how to go about, how to overcome these challenges. And they have devised various methods. One is a conventional enhanced delivery, focused ultrasound, neuron beam, BNCT, or you can say other systemic therapies like monoclonal antibodies, vaccinations, CAR T cells, small molecules, or targeted therapies. And let us see one by one. If you look at the EGFR targeting the glioblastoma, there are multiple phase 1 and phase 2 trials, but they are more or less failure. Why? There can be, because even if we target the EGFR, if even if this pathway is blocked, there are alternate pathways, and these get constitutively activated, and tumor depends upon this pathway for the growth and proliferation. So even if we block this pathway, alternate pathways sets in. Hence, these anti-GFR drugs have been failed. And also there is, this is a very interesting space and time concept, that suppose this is a tumor, and if we take a biopsy from the T1 part, it can be completely different. The mutations can be completely different from the uh, T3 part. So even if we take a biopsy, and even if we process it at molecular level, and even if it is EGFR positive, and we try to target that, it the glioblastoma is the tumor is very heterogeneous. There is lot of intratumoral heterogeneity is there, so it may not, that sample tissue may not reflect the entire uh, biology of the entire tumor specimen. One more vaccine targeting the EGFR deletion was uh, tried, but it's also failed. This trial also failed. You can see there is no survival benefit. They have clubbed this with the temozolomide, and then it is failed. And again, we see a lot of IDH mutation in the gliomas, mainly in the low-grade gliomas, and scientists have targeted this approach. And more, so you can see this IDH mutant gliomas are usually low-grade, and high-grade gliomas are IDH wild type. And to some extent, in the second line setting, the trials have been kind of positive, especially ivosidenib and vorasidenib, phase 1, phase 2 trials, and but other trials are still in research phases. But one trial is very, very interesting, Indigo trial. It's Uh, in the patients with IDH mutated low-grade glioma, they have randomized the patients into placebo versus vorasidenib, and they have shown that there is benefit, and that is reflected in the NCCN guidelines. The another interesting target for the gliomas is the BRAF, and it is also another therapeutically actionable mutations. But you can see the response rates are very, very low. And also the incidence of these BRAF mutations are higher in the pediatric tumor compared to the adult tumor. In the pediatric tumor, you can see it's more than 30 to 40%, whereas in the adult tumors, it's just uh, less than 5%. Hence, though it's a targetable mutation, but incidence is very, very low. That is another challenge. Again, even if we target this, there is other constitutive pathways activation, and then the tumor may not respond. Hence, again, a lot of uh, conflicting results are there with regard to the end. The trials are mainly case reports and basket trials, and you can see the best response are only. I mean, yeah, complete response is there, but it's just a case report, so we cannot rely on that. High response rates and significant clinical benefit is there, but so hence routine testing can be considered in clinical practice. Again, that is reflected in the NCCN guidelines, where you can definitely consider. And even if those 1 to 2% of the patient population are positive for BRAF, definitely we can target that. NTRK fusion, again, it is in 0.5 to 2% of all gliomas, and higher in the pediatric population. And FDA approval was done for the larotrectinib as well as entrectinib. If the mutations are positive, definitely we can target that. And disease response rates are, disease control rates are there, as well as durable responses are there. If it is mutated, definitely you can target that. Similarly, other pathways have been tested, and a lot of new therapies are being tested and tried. For example, MEK inhibitors, CAR T cell therapy, mTOR inhibitors. Lot of research is going on in this space. And one more in the, especially in the pediatric diffuse midline gliomas, H3K2M mutation is very, very common, and GD2 is highly expressed, and if you can able to target that, there is definite benefit. And this is very interesting case which was shared in the one of the article. You can see a patient before the therapy, he has deviation in the face, or you can say the facial palsy, and post CAR T cell therapy, the patient improved. So hence, if there is target, definitely you can, but most of these are case reports or anecdotal evidences rather than randomized control trials. And FGFR, it's a very rare in gliomas, and definitely if it's there, you can target that. So overall, as of now in 2026, how you approach the cases? If it is IDH, first you look at the IDH mutation. If it is mutated, you need to think in the lines of low grade gliomas. If it is wild type, you need to think in the terms of high grade gliomas. And further, in the low grade gliomas, you need to take the help of 1p19q codeletion, as well as the ATRX, CDK, and 2AB. These all things helps us to further classify into whether it is oligodendroglioma or astrocytoma, and if it is astrocytoma, whether it is grade 2 or grade 3. And we have got a very beautiful paper published in 2021. It's ASCO SNO guideline summarizing all the how the tumor evolved from 2007 to 2016, and in 2021 you can see if it in 2007 it is oligodendroglioma grade 2, but in 2016 they have introduced the molecular markers for the first time, and it is 1p19q codeletion. And in 2021, again, they have done a lot of reclassification, and you can see the Roman numericals have been replaced with just two. You can see that three with three. I don't know the reason, but they have done that. So this is my go-to slide. So first you can see the WHO 2021. First is the histology. You look at the histology and you classify it as whether oligodendroglioma or astrocytoma. And then you look at the IDH status. If it is IDH mutant, there is only one way. There is no other way. This is the only way. If it is IDH wild type, this is the only way. It cannot be IDH wild type and WHO 1p19 co-deletion. So that will not happen. So if it is IDH mutant, then next is do the histological grading, grade whether it is 2, 3 or 4, 2, 3 or 4. And then if it is IDH mutant, you do the 1p19q co-deletion and as well as the ATRX, and then you classify whether it is oligodendroglioma or astrocytoma. And if it is IDH wild type, straight away, just to simplify, you treat it like a glioblastoma. So as simple as that. And of course, treatment decisions are based on that. If it is oligodendroglioma, you treat it like a grade 2 or grade 3, you give RT followed by adjuvant PCV or RT followed by adjuvant temozolomide. Same thing applies for the astrocytoma. And if it is grade 4, you treat it like a glioblastoma where you give the concurrent temozolomide along with the RT followed by adjuvant temozolomide. So the future, it is very complicated, very complex, and they are looking at all the pathways that can be targeted, and so they are now looking into the PDGFR inhibitors, VEGF inhibitors. Of course, already bevacizumab is standard of care, and JAK inhibitors, STAT3 inhibitors. So a lot of research is going on, and most of them are in phase 1, phase 2 uh, trials. You can see there are multiple target pathways like PIK3CA, mTOR. They are looking into all these pathways. And another interesting article I have seen is the TNA methylation based classification of central nervous system tumor. So it is very, very complicated. What they are trying to do is basically they are trying to reclassify the histology and the molecular based classification into methylation based classes. We don't know, it may be the future standard of care, but for now it looks very complicated. But this space is continuously evolving. To summarize, high throughput molecular profiling techniques like NGS DNA methylation profiling has identified a new genetic and epigenetic changes in gliomas, and this has led to the classification of new tumor types, as you saw in 2016 and also 2021 classification. These advances have improved our understanding of glioma pathogenesis, but still there is a lot to learn, and it's very, very complex tumor. Novel therapeutic approaches for different gliomas entities have been developed, and a lot of research is going on. Key issues need to be resolved to translate these molecular insights into better clinical outcomes. So just because it has been, we got to know the pathway doesn't mean that that benefit translate into the real world scenario. So we need to be skeptical about that. Standardization, quality control of molecular testing procedures as per WHO 2021 criteria are very much essential across the world. And also, immunohistochemical surrogate markers may facilitate the diagnostic process according to the WHO classification, but it is not sufficient to cover the entire spectrum of biomarkers. And DNA methylation profiling, NGS technique, a lot of new techniques have come, and we need to make use of these latest techniques. And further challenges in glioma diagnostics relate to improving time to final diagnosis as well as molecular testing increases time to final diagnosis. So obviously, whenever we uh, send a sample for the molecular testing, it will increase the time to treatment. But you need to be careful that it should not cause delay of any post-surgical treatment. And challenges can only be met in close collaboration in a multidisciplinary collaborative team approach and tailored treatment strategies. So you need to include a molecular pathologist, radiation oncologist, neurosurgeon, medical oncologist, in radiologist and nuclear medicine physician in your team, and then we need to take a best decision for the patient. So with this, I conclude.
Thank you, sir, for that insightful overview.
Yeah.
Now we move on to our panel discussion titled Gliomas Balancing Precision, Timing, and Real World Outcomes. Joining Dr. Sushil Kumar Yashalla for this discussion as our moderator, and we have our esteemed panelist, Dr. Keval Kalavaria, consultant medical oncologist and hematologist, Nathalal Parikh Cancer Institute, Rajkot. But due to some last moment emergency, he won't be able to join. Dr. Joe Jose, Assistant Professor, Medical Oncology, Regional Cancer Center, Thiruvananthapuram. Dr. Uditya Goswami, Consultant Medical and Hemato-Oncologist, SP Mediford Hospital, Thiruvananthapuram. Dr. Karthik S. Tyagarajan, Consultant Radiation Oncologist, VS Hospital, Chennai. Dr. Indu Bansal Agarwal, Group Director and Head, Radiation Oncologist, Paras Health, Gurugram. Dr. Ritika Menia, Assistant Professor, Pathologist, AIMS Hospital, Jammu. Over to our moderator. We welcome, sir.
Yeah. So a very thank you to all the esteemed panelists who are present, who have taken out time on your busy day to participate in this discussion. So I sincerely thank you. And now I'll be sharing the screen. Is my screen visible?
Yes,
Yes,
sir.
sir.
Okay. So we have here Dr. Keval Kavadia, medical oncologist, Dr. Jojos, medical oncologist, Dr. Ruditya, medical oncologist, Dr. Karthik, radiation oncologist, Dr. Indu ma'am, very well-known and senior radiation oncologist, and Dr. Ritika Minia, again very senior oncopathologist, ma'am. So I sincerely welcome to this wonderful panel discussion. So without wasting time, let's go to the case one. So, when molecular biology disagrees with itself, so who do we trust? So, that is the theme of this uh, case one. So, here is a 23-year-old male who had history of seizures, vomiting in March 2026, and MRI brain was done. There is a sol in the left frontal region, underwent left parietal craniotomy with subtotal resection in March, and histopathology reported as oligoastrocytoma, CNS WHO grade 2. So my first question is to Dr. Ritika ma'am. Ma'am, do you still use this terminology of oligoastrocytoma, or you will directly either give it as oligodendroglioma or astrocytoma? What is your opinion?
Good evening, sir. So we do not use this terminology. We would, sir, go for further testing, and we would like to diagnose it in the form of oligodendroglioma with IDH mutant and 1p co19 co-deletion, and then final diagnosis will be made. This terminology is not used
Yes,
currently.
agreed with ma'am. So this is a in 2000 till 2007 or maybe till 2016 we used to use this terminology, but as of 2016 update, this is a obsolete terminology. Either you need to classify it as oligodendroglioma or astrocytoma with clear integrated molecular diagnosis. So once this patient underwent surgery, histopathology, as I discussed, they have given it as oligoastrocytoma. But however, in on molecular profiling, the patient is IDH1 negative, that is wild type, 1p19q co-deleted as well as ATRX retained, MGMTs positive. So under WHO 2021, does this tumor even exist? So they say that it is IDH wild type. You can see this is, sorry. Yeah. So they say it is IDH wild type. 1 minute. Let me annotate. Let me add the
It is
annotation.
not IDH mutant, and but it is still showing 1p19q co-deletion. It is showing
Correct.
ATRX is retained, MGMT methylated, but it is not falling under IDH wild type also properly. So
Why do you
Dr.
think?
Sushil, may I add something
Yes.
here?
Yes, ma'am, please.
I think if a patient is showing 1p19q co-deleted and we have
Mhm.
done only IDH1 mutation, then IDH2 mutation should be tested before labeling it as IDH negative. So I think
Absolutely.
PCR sequencing should have been done in this patient because we have done this is falling into 1p19q co-deletion positive because Atrex is retained.
yeah.
Correct. Completely agree with that. So,
So it's going towards oligodendroglioma because there is no Atrix loss. So I think we cannot label this patient as IDH wild type without doing IDH2 mutation, which can be done by PCR testing.
agreed, ma'am.
So this is an incomplete report. Yeah.
Yes, completely. But most of the times, whenever we send the patient molecular profiling for the first time, since this is the most common, 70 to 80% of the tumors are IDH1 mutated. Hence, usually they do with the IHC, and most of them can be positive or positive. Okay, you need not do the sequencing, but if it is negative, we need to rethink the diagnosis because if it is IDH mutant, that is fine. Then 1p19q co-deletion can happen. But if it is IDH wild type, then we need to uh, think that something is missing. That's what ma'am have told. So
I also
IHC,
want to add one
yes.
thing more here. I
Hmm.
mean, in situation number one, like either this patient was sent directly for NGS because normally 1p19q co-deletion is not ordered at all if it's a IDH wild type tumor. So here, so 5% of the patients may show IDH2 mutation. So that's why before labeling any patient in a low grade patient, grade 2 tumor, young patient, 45 years of age, without knowing IDH2 mutation, labeling the patient as IDH wild type is not good. And second thing, I think TERT mutation could also have been done, which can be easily be done by IHC. And in such situations, if uh, TERT is mutated, it goes in favor of oligodendroglioma, and if TERT is negative, it goes in favor of astrocytoma. So I think in this patient, the molecular profiling is not complete. So I would first like to do the molecular profiling completely before labeling this patient as oligo dendroglioma. And second thing, in the radiology, the report is not full. So we don't know if suppose there were calcifications or chicken wire appearance or fried egg appearance on radiology also. That also points out towards oligodendroglioma. The radiology is also very, very important. So I think when we are discussing such cases, complete radiology report of the patient is also very important before we start discussing on such patients.
Yeah. So here I want to highlight one point is that even if the radiology says high grade, even if there is all the high grade features, if the molecular report says that it is IDH mutant, we have to treat it like a low grade glioma because now it is no more radiology, no more clinical this thing. It's no more even the histopathology. It's completely our treatment is based on the molecular markers rather than the other like other radiological features. So hence, but point well taken, ma'am. Point well taken. And so whenever we are labeling it as IDH wild type, we need to look at whether both the IDH1 and IDH2 have been done or not. Most of the cases, they do IDH1 because it is the most common. So just because if it is IDH wild type and 1p19q is non-deleted, then you can label it as high-grade glioma. But here the report is discordant, so this tumor doesn't exist. Hence, we need to rethink upon the IDH status, and that's what uh, even the NCCN guidelines endorse, that IHC can miss 10 to 15% of IDH mutations because it only detects the most common. Canonical variants are the most common variants. So leading to dangerous false negatives. Hence, R132H is the most common IDH1 IHC testing done. And if it is wild type, then you need to do the IDH1 and 2, and you do it with the help of PCR plus sequencing, and that's what we have done. Again, we have proceeded with the IDH1 and IDH2 mutation on PCR and sequencing. Again, it is wild type. So now there are no misses. Now the tumor is IDH wild type and 1p19q co-deletion. So now, what is your take, like Dr. Ritika ma'am and Indu ma'am? What are your takes?
Because sequencing is quite specific, so then we need to believe that it is IDH wild type only. But since it is not 1p19q co-deletion, so still I would not label it as oligodendroglioma. Maybe and I would like to give a blanket term, or maybe diffuse glioma. I would like to sign it out maybe in a safer way. And
Okay,
further molecular studies, I would recommend, like maybe NGS could be done, so that we could be more specific. Because this PCR sequencing, although it is very helpful in diagnosis, but still maybe sometimes we may proceed with further testing, and also that we can confirm whatever the diagnosis was made on this thing.
okay. So if you have to believe these two reports, like now uh, this is okay. Let me go back to the this report. So again, IDH status confirmed by gene sequencing and absence of mutation by IDH1 codon 132 or IDH codon 172 should be confirmed by gene sequencing, like ma'am was telling. But what if the gene sequencing also says that it is IDH wild type, but still 1p19q co-deletion? So now, what is your take?
So
So
I
there are two
think for to
reports.
label any patient as oligodendroglioma, both IDH mutation and 1p19q should be co-deleted. And
Correct.
as I said, maybe TERT mutation is a simple test which can be done, on IHC. So like IDH1 mutation can be done on IHC, but IDH2 is done on PCR. And because I don't think that any entity oligodendroglioma exists where IDH is non-mutated and 1p19q is co-deleted. So there is some problem in the report. So these discordant reports should be cross-checked by from another lab. And I mean,
So
I would not label it as
Dr.
oligodendroglioma in
Sushil, I
spite
had
of
a point.
1p19q
yes, yes,
co-deletion.
please. I'm coming to you. Yeah.
Yeah.
Dr. Udipya, please.
Yes. So I think you had also mentioned one of the slides, and as Indu madam and Ritika madam was mentioning, I feel that since the 1p19q co-deletion is more of a fish-based test, we would have to actually recheck that first once more. And there are data, even though it is very rare, but then there are some 3 to 5% patients who can have a false positive uh, report of 1p19q. So
Correct.
I feel that the one that you were asking of IDH versus the 1p19q, I would be trusting the IDH much more than the 1p19q, because there can be false positive reports, and there is some literature behind that.
Correct. What about you, Dr. Joe? Any comments?
Yes, was we. I mean, amongst the two mutations, you got IDH and 1p19q. I would go with the. I would trust the IDH report more because we have done we have done the IHC, we've done sequencing, so we have sort of comprehensively ruled out the presence of such a mutation. But 1p19q, once again, as Dr. Aditya mentioned, there can be false positives with fish, and we would need a more complex sequencing to further delineate whether that mutation exists or not.
Correct. Even the insistent, so the standard guidelines caution against overrelying on the targeted assets like fish. So if at all we have to trust between these two, I would also go with the IDH sequencing. I would trust more of IDH sequencing rather than fish based, because fish based can miss a few. It may not cover entire genome, and NCCN also tells that the correlation of 1p19q is detectable by array-based genomic copy number testing, and it is preferable. Why? Because it can cover the entire genome and fish may miss that. Hence, if at all I have to believe between the two reports, I would also definitely believe the IDH mutation rather than the fish, because fish, why we are thinking that IDH is has been missed, mutation has been missed, why not fish? So there is evidence that fish can miss. And coming to Dr. Karthik, so if you are sitting in the tumor board with this uncertainty, would you radiate this? So at last we come down to the same question. So
Mm.
now this patient has landed up in your OPD, and you want to treat it like a grade 2 oligodendroglioma, or you
Mm.
want to treat it like a GBM.
Yeah, so good evening.
Mm.
So I would actually go with it as an aggressive disease. As already discussed, going between IDH and 1p19q, I would also go with IDH forms. And being a young patient, better you go, and I think it's a subtotal resection, so you go for 60 gray, treating it as an aggressive disease. And of course, we need more radiological evidence and more molecular reports. But as of now, with the reports we have, I would definitely go for 60 gray, taking into account the critical structures received less than 54.
Okay, ma'am. Any comments from Indu, ma'am?
So I think this patient should be treated as IDH wild type only because both the IDH has been tested very nicely and PCR testing has also been done and it is showing negativity. One thing which is the only ray of hope in this patient that I see is NGMT methylation positive. So it
Correct.
means that temozolomide will work
Works.
in this case. So it should be treated as IDH wild type
Wild type.
grade 4. I mean, so that's why 60 gray dose would be given, although it is showing as grade 2, but IDH wild type becomes grade 4 only. So it should be treated as grade 4, 60 gray, 30 fractions plus concurrent and adjuvant temozolomide.
Yes,
That would be
I
the
would also
preference.
definitely agree, because this patient came to us and we were also in dilemma on what to do. So even we had considered these points and started considering treating like a aggressive disease. So now we can see the arguments for 60 gray, that it is subtotal resection, IDH wild type on sequencing, under treatment risk is there, young patient, and he can tolerate, he has entire life ahead. So you tend to be a bit more aggressive. But again, arguments for the 54 grays, potential missed oligodendroglioma, like PCR sequencing may miss IDH, few IDH mutations. Hence, there is a all the reasons to miss that, and neurotoxicity concern. So there is difference. The dose tolerance for the nervous tissue is 54 gray, and if you go beyond that, again there can be a neurotoxicity concerns considering the age and neurocognitive defects. So again, my question to Dr. Karthik and Indu ma'am, would proton therapy change your comfort level? So suppose, okay, I thought one of you may answer, you may go with the 54 gray, hence I have put this question. But anyway, we are treating like a 60 gray. Suppose, let's say that we are considering uh, it as a uh, low grade, but just to be on the safer side, you want to step up on the dose. And would proton therapy change your comfort level in a young patient like this to step up to the 60 gray?
So, see, whatever literature on proton that we have till date, it has not shown any survival benefit for high-grade gliomas.
Mhm.
Any literature you see, it is not even recommended as per the proton statement. For low-grade gliomas, I mean grade 1, grade 2, IDH mutated, oligodendrogliomas, MGMT methylated, the patients which I'm expecting a long survival, then I will discuss proton with them. But whatever results that we have, they are not showing any survival benefit. So even in the proton series, even for low-grade gliomas, the survival benefit has not been seen, but definitely the neurocognition is better with protons. The hormone profile is better, and maybe hippocampal sparing and brainstem sparing and all those structures would be better because this tumor is located in the frontal area. So what I would be concerned is about the doses to the hippocampus, the optic apparatus, as well as the pituitary and the left temporal lobe. These are the areas that would be my area of concern. So, but because it is grade 4, I don't see any benefit of protons, but I will tell the patient and give put both the options on the table. The one thing that has been seen with protons is that when you are treating with protons, then the lymphopenia is slightly lesser. So patients who are on concurrent temozolomide, so lymphopenia is slightly lesser. So that has been seen as some advantage because immunity is better if the lymphopenia is lesser. But apart from that, for a grade IDH non-mutated tumor, survival benefit is definitely not going to be there. So if patient wants a better neurocognition for whatever survival they have, and they're willing to accept the high cost that proton has as compared to photons, then yes, that has to be discussed in view of young age. But for an elderly patient, say if the same patient was 55 or 60 years of age, I would not offer protons to them in such if it was a similar patient but an elderly patient.
Got it, got it. What about the late neurocognitive toxicities you can expect in a patient who survives more than 10 to 15 years with this 60
So
gray?
So if it was a grade 2 mutated tumor and grade 2 IDH mutated, 1p19q co-deleted, MGMT methylated, then as I said that if I'm treating a left-sided frontal tumor, I'm more concerned about the doses to the hippocampus because that is one area neurocognition would be affected in this patient and optic apparatus would be close to it. And in a study by Dr. Jalali et al., it has been seen, although that was for pediatric patients, but in adults, the doses have not been calculated. But the left medial temporal lobe, if it gets more than 13 grade, then the neurotoxicity is much more. So and of course, gray matter thinning and cortical thinning, these are some of the long-term effects. But these days we do hippocampal sparing even with photons, and we do add Edmenta or Mementin, and it has been in all my patients. I give them Mementin and do scalp sparing radiation. So it's not just the neurocognition that is at stake, but for a very young patient, if I'm expecting 10 to 15 years of life, then I would be really bothered about the hair loss also. So I would be doing a scalp sparing, hippocampal sparing radiation if the tumor is away from the hippocampus and it can be saved. At least right side, I would definitely like to save. And at cochlear doses, I would be really concerned about. And pituitary is something, growth hormone deficiency and all that, I would keep a watch on for these young patients. And these patients, for long term, if they live many years, then stroke. Although it is seen more in younger patients, it would not be much of a concern in this patient. But hair loss, neurocognition, growth hormone deficiencies, these are the main areas that I would
Okay.
be
Excellent
focused about,
insights.
and they have to be counseled about this patient. And one thing which is also very important if we are expecting 10 to 15 years of survival is that they have to be told that they need a long-term follow-up because this patient may recur late because otherwise these patients they stop coming after 3 to 5 years. And if the patient is a young patient and he's planning for a family and I'm giving temozolomide, then I have to counsel them regarding fertility and reproductive health of the wife, and the wife should not get pregnant. So these are the
Correct,
certain
correct.
things that I would keep in mind while treating such a patient.
Yes, yes, definitely very, very practical insights from ma'am. And what any comments, Dr. Karthik?
Yes, it's almost, I think ma'am has told in detail. That was very nice to hear. So the thing is, I would discuss proton because of young age. That is one thing. Because we definitely do not have a survival benefit. And
Mhm.
because of the young age, I would definitely discuss with the patient because later on, because of the neurotoxicity concerns. And the second thing is definitely he might recur in 10 to 15 years age. One thing is I will be worried about is the optic structures, that is the chiasm and optic apparatus, entire apparatus, and of course the brainstem dose as well as the hippocampus. Because being a young patient, he might recur late, and after 2 years, if you get a neurocognitive decline, that would be very bad on the treatment. So definitely, I would take into account those factors and spare them while giving radiation.
Okay, excellent. So now coming to the Dr. Joe. So would anyone still strongly advocate RTPCV here? But RTPCV is for the low grade glioma. But however, what is your take on this?
Yes, sir. So I think the panelists have already established that we are going along the lines of treating it as a high grade
Mhm.
glioblastoma sort of. We've decided on the dose of 60 gray, so on and so forth. Also, if you look at the evidence for PCV regimen, we have two trials. We have a ERTC trial. We have the RTOG 9802 trial as well. So
Mhm.
they had a subgroup analysis there of 1p19q co-deleted IDH mutant patients, which benefited the most. Then
Mhm.
IDH mutant alone, which benefited the second most, and the IDH wild type patients benefited the least. So just
Mhm.
looking at that data, although it doesn't strictly apply to this scenario, which is very rare, I would go more of with temozolomide based concurrent temozolomide as far as followed by adjuvant temozolomide for 6 months, just like the Stoop protocol is what I would stick to.
Okay, okay, got it. So now, any comments, Dr. Udiptya?
No, I think it has been very nicely told, and
Summarized by
I
Dr.
don't
Joe.
have any other points to add here actually. And to be fair, we would really treat it like a glioblastoma and choose on doing a MGMT methylation, prognosticating the family, and
Mhm.
going ahead with temozolomide.
Okay, so we all kind of agree to treat it like a high-grade glioma. So, in such kind of molecular ambiguity, is under-treatment more dangerous than over-treatment? What are your comments, Dr. Ju and Dr. Uditya?
Yeah, in this sort of a scenario, a young patient, there's every chance that it's an aggressive disease. IDH is wild type. I think we have to, go for the kill. I mean, go guns blazing and,
Mhm.
over treat the patient. I mean, given the scenario, we have to go with the best treatment, the most aggressive treatment possible. I think that's the right thing to do, given this particular scenario.
Okay, yes. Dr. Uditya?
Absolutely. I think we have already established, and our panel is very much in sync with everyone. So we would just go for the kill, actually. Yeah.
Correct. And also, we know that temozolomide is very well tolerable. I
And I
mean,
think the only thing that is stopping us from temozolomide, as Madam mentioned, is about the fertility and things like that. But then I think in this scenario, we would prefer temozolomide rather than thinking about fertility because, like
yeah.
aggressive disease, we have to save
Yeah,
the
life
husband.
over fertility.
Yes,
So,
yes,
point
absolutely.
well taken. So, if advanced testing is unavailable in real world, yeah, that's what we are discussing. So, everybody, we tend to treat like a aggressive disease for this patient rather than low grade glioma. So, what are the take home messages? Molecular drivers eclipse the histology. So, hence, molecular testing is so important. Even the pathologist says it is a oligo, even if the oligodendroglioma and the pathologist has given grade 2, but still Based on the molecular profile, we all agree that we need to be aggressive in this patient and treat like a IDH wild type or aggressive biology. Hence, the molecular drivers eclipse the histology, but only when the biology is trustworthy. Discordant molecular results should trigger rethinking. So we need to rethink. We need to not just see at the 1p19q codeletion. So it is correlated. Let me treat it like a low-grade glioma. You need to go in a very sequential manner. First, you need to look at the histology, then grading, then IDH, then 1p19q codeletion and ATRX. So that there is a sequence, and that's how we should. And any discordance in this sequence, we need to rethink and we need to recheck with the pathologist. And sometimes the real tumor board decision is deciding which test to believe, like in this case. So, uh, okay, moving on to the next case. I request, I think my slides are kind of, yeah, these are the slides. Okay. So the theme of this case is recurrent GBM. Are we treating tumor biology or preserving the function? Because most of the times, this patient is an elderly gentleman who has a recurrence on treatment on adjuvant temozolomide. So now our goal is to control the disease or to maintain the quality of life. So we all have been in this conflicting scenario, and let's dissect more of this scenario. She is a 71-year-old hypertensive diagnosed case of GBM in August 2024, underwent craniotomy, gross total resection, histopathology, clear cut, no doubt. It's a WHO grade 4 IDH wild type GBM, and he received adjuvant CTRT with concurrent temozolomide, followed by adjuvant temozolomide 6 cycles. And during the 6th cycle, the patient complained of weakness, and MRI was done, and that showed progression of disease. And the patient was started on bevacizumab in the second line bevacizumab. Post 6 cycles, it was more or less stable disease, but post 12 cycle, the patient had partial response. So my question is to the medical oncologist or everyone, would everyone here have done the same thing, or you would have done anything different in this case? Dr. Joe, you go ahead. Dr. Joe? Dr. Ruditya?
Yes, I think this is a good laid out plan and has been done at the right time. I think diagnosed in August 24 and then CTRT followed by concurrent temozolomide. Looks good to me actually. And then there's a recurrence and started on bevacizumab. Obviously, there is not a great data of bevacizumab yeah, at the level of the OS, but then I think the well laid out plan. I don't see any difficulty here.
So fair enough.
Yeah,
Real world,
I'll
very, yeah.
if I may just
Dr.
add,
Joe.
I mean, I don't know the exact details, but in progressive disease, first of all, since it's quickly progressed actually.
Correct.
So I would do a few more things here.
Correct.
I would establish whether it is like a pseudo progression because it's very close to or not that far away from radiation. So imaging is going to be super important. If possible imaging does not establish, I might also consider a biopsy in that scenario.
It's a clear-cut progressive disease. We'll
Yes.
discuss in that line.
Yes, sir. So apart from that, I would consider, if possible, maximal safe resection or re-radiation also. I mean, I don't know the exact details of the case, but
No
those two
problem.
components also.
This is a scenario. You tell your view so that it's a open discussion.
Yeah, I would always, in a relapse glioblastoma, I would always consider maximal safe resection because that's although the outcomes are dismal overall, but that's the best option that we can give the patient. And also, if that's not feasible, then re-radiation also needs to be discussed at
Okay,
some
we'll
point.
come to that part, re-radiation part. Indu ma'am, please tell.
Yeah, so I would agree with the previous speaker. There's a lot of disturbance from outside my cabin. But I think in any case of recurrent setting, and specifically if the patient has recurred within 6 months of temozolomide or the patient has progressed on temozolomide. And initially, because there was a gross total resection, so maybe this patient definitely needs a surgical opinion. And if they can do any debulking or I mean they can remove it, and we should also send NGS at this time, because if biopsy and if we are able to do an NGS testing, it would be beneficial. So surgical opinion, if it's inoperable, then we have no other choice than to start BEV, because he has progressed on temozolomide and in a short period of time, and within 6 months I would not be very happy to radiate. So in
Correct.
such a situation, BEV is a decent option.
Okay. And what about Dr. Karthik? Any?
Yes, sir. So the thing is, again, we've radiated him very recently, that is in October 2024. And in May 2025, that's a progressive disease, which means it's a very aggressive disease. But re-radiation can be considered only in very carefully selected patients, depending, we would look at the performance status and the symptoms of the patient.
Correct.
If at all, he definitely requires any symptoms to palliate, and if the patient understands that it's not going to be a curative intent. And the timeline again is, I would consider safe timeline is after 1 year of re-radiation of radiation. Then after explaining to the patient, maybe we can consider something like stereotactic form of radiation, that only in very selected patients.
Okay, agreed. So in this case, as everybody told that there is incomplete information, I completely agree with that. So in May 2025, when the patient progressed, his ECOG was kind of 2-3, mostly wheelchair bound, and neurosurgeon opinion was taken, and neurosurgeon told that he'll not kind of due to poor performance status, not an ideal candidate for surgery. Hence, we need to start upon the some kind of therapy, hence started upon the bevacizumab. So rebiopsy was not possible. Definitely that should be considered. Again, a very interesting point by Dr. Joe. We need to, whenever patient progressing upon the treatment, we need to rule out between the radiation, I mean pseudo progression versus true progression. That is first point. Next point, always try to go with the re-resection if feasible, because that is what going to give us maximum benefit. Third point, in case if re-resection is not possible, maybe we can do some kind of testing, maybe rebiopsy, stereotactic biopsy, followed by molecular testing. And even if that is not possible, we can go with the blood-based NGS. So none of these patient was interested. Hence, we had no other option than to start
What
on.
was the MGMT methylation in this patient, doctor?
It
Was
was
it
not
done?
done.
Because
It was not done upfront.
yeah,
So
because why I asked this question was that if this patient was MGMT methylated, then the chances of pseudo progression are more as compared to for a non-methylated tumors, because
agreed.
so that's what keep a watch on. So if my patient is GBM but still MGMT methylated, and I have a doubt that this patient, it could be a pseudo progression or a true progression, then maybe continuing temozolomide for maybe for another 1 or 2 months and repeating an MRI. And if it's a true progression, and then changing the drug is an option. But if it's an unmethylated tumor and it's a true progression as per RANO criteria, then definitely the treatment needs to be changed.
Exactly. So it's a true progression. We have ruled out the pseudo progression, and MGMT definitely, if it is there, we know that it responds well to the alkylating agents like temozolomide, lomustine, and since it responds better, so there is no question of progression. So very point very well taken. So now the question is to the pathologist, Dr. Ritika ma'am. Do recurrent gliomas deserve rebiopsy? What is your take on this?
So,
I think there is some echo.
yeah.
So, what about you? I think Dr. Joe has clearly told that he would consider rebiopsy. What about Dr. Uditya and Dr. Karthik?
Yeah, so I think
I think the trouble with Madam is that two devices are I think logged
Log,
into Zoom.
logged
Yeah,
in.
sometimes that happens.
Mhm. Okay, you can go ahead, Dr. Uditya.
Yeah, I
Yes
feel
or
that
no?
why I was little hesitant is that a 71-year-old
Correct.
progressing so soon, how much feasible a rebiopsy would be is the biggest challenge here. But then I'm
Correct.
sure that yes, recurrent gliomas, we cannot taken it for granted that whether the molecular biology has changed. And now that we have so much data on targets and other things. So I think I'm sure that a rebiopsy should be attempted, but how much it would be feasible in the real world is my doubt.
Correct, correct. So whenever feasible, wherever feasible, we need to do the rebiopsy. Until
Absolutely.
and unless if the patient has poor performance status, if the patient is not agreeing, then obviously we have no other option than to skip that. Because the point why I raised regarding the rebiopsy is that whenever we give some kind of therapy uh, with regard to the I mean even surgery, radiation, temozolomide, so the nature of the tumor changes, and it may not be the same tumor that was upfront. The innate nature of the tumor changes. Hence, we are looking at uh, the reason for progression. So maybe the tumor might have acquired mutations. Hence, that is the main intent of doing the rebiopsy. So that's what why retesting it, recurrence tumor evolution after prior therapy can be there, genomic changes can be there, temozolomide drives new biology. So hence repeat biopsy is a standard, and if it's not possible, liquid biopsy can be attempted. And like you can see here in the left bottom, fit patient, you do the repeat surgical biopsy, but here the patient is frail, ECOG 3, hence we would have definitely considered for the CSF and blood-based molecular profiling. Again, here comes the patient financial status, and the patient will not be affordable. Hence, we need to take the hard call. So now my question is to Dr. Joe and Dr. Uditya. We all know bevacizumab improves PFS, but there is no OS benefit. Then why most of the medical oncologists use it? Why we use it a lot?
Yes, sir. If I may, so bevacizumab actually we used it in our practice. It's actually a wonder drug in the relapsed GBM. It's not about extending the life, as the data clearly shows there's no worse benefit, but at least you can add quality to the patient's life. So it takes care of the peritumoral edema. So it reduces the steroid dependency, so all the steroid side effects can be avoided, and definitely it improves the quality of the patient's life. So even single agent bevacizumab can ensure that the patient is relatively symptom free while taking the treatment. So it's something that you would advocate to any patient, especially if they are symptomatic.
Correct. What about you, Dr. Uditya?
Absolutely. I think one line that would define is that because recurrent GBMs are like largely incurable. So we are not talking about OS at all here. So we would value the short-term neurological improvement. We would value the reduction in the steroid toxicity. And that we know that survival won't change. So it would be just adding value to the life, quality of life should be maintained. And that's why bevacizumab has been a wonder drug, as Joe mentioned, actually.
Correct. So, even in the recurrent GBM, the average time survival we give is 6 months, and this patient has already received 12 cycles, so every 2 weekly. So, he has already crossed that and he's doing well. So, it's not just about the tumor control, but also quality of life and the patient. I think though the disease is stable radiologically post 6 cycles, but the patient quality of life really improved. He was able to stand up, he was able to walk, his weakness decreased. So that's what we want for a patient whom we know that there is no cure.
May I add something here,
Yes,
Dr. Sushil?
yes, ma'am.
I would like to differ a bit here because what I have seen, although people say that it's a wonder drug, but I would not say the same because it basically reduces the peritumoral edema. But because these are infiltrative nature of the GBM7 infiltrative nature of disease, so usually the disease does not regress. It's only the peritumoral edema. So I agree with everyone that the requirement for steroids goes down. And because of the steroid related toxicity goes down, so the quality of life improves. But the problem is, what if the patient is at least 1 year from the previous radiation, and it can still be covered in the radiation field, then re-radiation is a better option than offering bevacizumab at the same time, because if you give re-radiation, you can give progression-free survival of 6 to 7 months. And because if you give Bev first, then the patients usually recur with a multifocal recurrence, and then re-radiation is not a possibility. But if you offer re-radiation after the first relapse, if it's can be covered in the radiation field, and then you add bevacizumab, then you add 6 months by giving re-radiation, and then another few months by adding Bev. So this is one point that I want to make, and it's so re-radiation can be given either by FSRS, like you give 5 sittings of 30 grain 5 fractions or something like that, or if it's a larger tumor, then you can give 30 grain 17 fractions also. So there are guidelines how to do a re-radiation. And one more thing, I don't know, I've recently started adding, and I've seen some good results in patients where the radiation-induced edema is a concern. Then boswellic acid, boswellia, it has shown good results in help in reducing radiation-induced edema. So I recently treated a patient with re-radiation, and patient was having needing a large dose of steroids. I was not able to taper it, and he was a diabetic patient, so he would land up with electrolyte disturbances and all those problems. But I added Boswellia, which is now easily available in the market, and the steroid requirement went down substantially. So I have kept Bev as a reserve drug, and rather than giving.
But in this case, the recurrence is after 6 months of completion
Yeah,
of
not in this
radiation.
case. Not
Yes,
in
but
this case.
yes,
That's what I said. For this patient, I'm
correct,
absolutely in agreement with everyone that Bev
correct.
at 6 months was a good choice. But that's what I said. If it was the patient had recurred after 1 year or maybe a longer
Yes,
period, then
correct.
re-radiation would have been a better option.
Definitely, we'll definitely come to the re-radiation part. So now again coming to Dr. Joe and Dr. Udiptya, would anyone have added lomustine? So because the data is mainly on bevacizumab with lomustine versus lomustine, so would you consider or not?
Yeah, so when it comes to adding Lomeston, you'll think twice, because actually, if you look at, there's a meta-analysis done. There are also phase 3 and 2 studies done. There is no consistent OS benefit from adding Lomeston as such, and we'd just be adding added toxicity. We're talking about an incurable disease here, so we'd be adding added toxicity. So we might have to really think hard about adding Lomestin. It shouldn't be a given for all the patients, is what I feel.
Yes. What about you, Dr. Udiptya?
To be fair, like I'm only aware of the Lomastine data because I have not used it yet. But then I am aware of a little bit of data on irinotecan and bevacizumab,
Correct,
because
correct.
we have used for a few patients,
Yes,
and
correct.
that has actually helped. So, as and in this scenario, if it was a MGMT methylated patient, and if you are talk instead of this 71-year-old, if it was the previous boy of 23-year-old who would have presented like this, I would have been tempted to give a temozolomide with a inotican and a bevacizumab combination.
Yes, that is very, very practical. Even during my training, we used to give a lot of bevacizumab with irinotecan combinations. In this case, we have discussed the current case in our international tumor board meeting, which happens every week. So even they were also skeptical to add lomustine, though there is data. So hence we went ahead with the only bevacizumab, and lomustine can be considered only in young fit patients, like Dr. Joe has told. So We have definitely evidence of adding lomustine to the bevacizumab, but sometimes it is very toxic. It's not an easy drug to handle. Hence, some advocate for sequencing. You may start with the lomustine and then you may uh, uh, add the bevacizumab later. Or sometimes prior temozolomide exposure can force tumor evolution. So previously it might be MGMT methylated, but now the patient may be alkylated. So whenever we are planning to add upon the lomustine, we should be very careful, especially in the temozolomide exposed patient. And how long do you continue upon the bevacizumab?
Yes, sir. Sir, I would continue 10 milligram per kg every 2 weekly is what we give. Certain patients we give 5 milligram per kg 2 weekly. So I'd like to continue till there's either concrete evidence of disease progression, or if the side effects of bevacizumab kick in, such as proteinuria or symptomatic press, or if there's any thrombosis, etc.
What about you, Dr. Uditya?
Absolutely, absolutely. It's the same like our mantra that we used to learn in training, that continue until progression or unacceptable toxicity.
So yeah, the same principle applies elsewhere, everywhere, and GBM is no exception to that. And would you do MGMT methylation? Would MGMT methylation influence the salvage strategy? Like just now we were discussing on the lomustine.
I feel that in this scenario, if we are not going to use lomustine, which then doing a MGMT methylation, how much it would benefit in this patient of a 71-year-old who is already on bevacizumab, I doubt. But then, overall, I don't really see a reason why I should do a MGMT methylation unless I really want to re-challenge with temozolomide again.
So
If I run out of.
if it, suppose let us assume that this patient is young, fit, and recurred. So maybe after 6 to 12 months or post therapy, the patient recurred. So would you still do, or would you skip it?
I think as Madam was mentioning that doing a MGMT methylation would only make sense if I am going to rule out a pseudo versus a real progression. But since we are talking about real progression here, in the recurrent setting, I don't see a reason why I should do MGMT methylation. If I have to re-challenge with temozolomide, I would do it anyways. So
Yeah, so we have to be a bit careful when we do the MGMT methylation testing in a temozolomide exposed patients. But however, if the patient is not exposed, then we may definitely consider, because this is a indirect marker for the response to the alkylating agent, as simple as that. So now question to Dr. Karthikeyan, ma'am. Would you consider re-irradiation in this case? It is 6 months post progress, 6 months post radiation, progression on adjuvant temozolomide. So, and what are your selection criteria?
So within 6 months of re-radiation, when the patient has received full dose, 60 grain, 30 fractions, I would not consider re-radiation. But of course, before ruling it out, I have to see where is the progression. So if it is inside the radiation field and it's inside the full dose radiation field, then definitely re-radiation is out. But if suppose patient has a recurrence which is outside the radiation field, because some patients may have multifocal GBM and the first lesion might not have shown up initially, or sometimes when we go back and review the previous slides, then we see that there was a small speck of a multifocal glioma which was not taken out by the surgeon, and it was just an evolving glioma. So in such a situation, if it's outside the radiation field, then I might still consider, but within 6 months, I will not in this particular patient. No.
Okay. So you have any go-to checklist when you're planning to select upon these patients for re-irradiation?
So yes, one is how much was the dose of radiation which was received before? What was the time gap between the previous radiation and the recurrence? what is the tumor biology of the patient? Like if it's an IDH mutated tumor, do I have any molecular marker? Is surgery possible? Because if surgery is possible, then I would prefer resurgery in a recurrent setting. And then, as I said, if the recurrence is inside the radiation field, it's outside the radiation field. Whether it's a true progression or a pseudo progression, whether the tumor is sitting very close to the critical structures, and how much residual dose is left from the previous radiation field. And at the time of re-radiation, we always want to have the data from if the patient has not been treated at our center, then we try to get the DVH, the radiation planning scans. We fuse the previous scans of the MRI and see it's a true recurrence or a outside field recurrence. So all these things have to be considered. And as I said, that how much is the volume of recurrence? So if it's a small volume recurrence, it's a large time gap between the first radiation and second radiation, then I might consider only fractionated stereotactic radiosurgery. But if it's a large recurrence, patient is symptomatic, and it's a large recurrence, patient is symptomatic in the form of throwing seizures, and I can give some palliative relief to the patient. And if the patient is non-affording for BEV also. So these are certain things. I mean, we have to look into many parameters before we start for re-radiation, because and if the patient is diabetic, the requirement of steroids also goes up. So re-radiation is not a very easy thing to give. It adds to a lot of toxicity and morbidity. So
Correct.
re-radiation is to be thought of before you offer it to any of your patients.
Yes, yes. What about Dr. Karthik?
Definitely, if surgery is as an option and it is feasible, that would be the first option. And because re-radiation, do it only after a period of 1 year time. So after 1 year, maybe looking at the dose that was given earlier, the dose that was received by the tumor, and in that area, how much dose was received, and also the critical structures nearby has received how much of dose in the previous radiation. So then we will be left with radiation doses which can be given in the next sitting, that is in the re-radiation, which is always a difficult task. And the second thing is we need to check if radiation is going to be given, re-radiation is considered at what cost and what benefit. That is, if it is going to cause more morbidity, then definitely we are going to avoid re-radiation. And one more thing is if the patient has symptoms and the performance status of the patient, will re-radiation definitely benefit the patient in any cost. And as Madam rightly mentioned, if it's a large volume, then we can only palliate the patient and just relieve the symptoms. If it is a small volume, then small volume fitting into other factors such as it is outside the radiation field and other critical factors are also not getting affected, then we can plan serotactic or hypofractionated radiation depending, but always 1 year time is a safer period for re-radiation.
My another doubt to Dr. Karthik and Dr. Indu ma'am. So both of you are told that if it is small volume tumor, we give the stereotactic radiation. But we do know that GBM it spreads beyond certain boundary. Is it safe to give stereotactic radiation because we need to give larger margins because these cells are known to diffuse beyond 2 centimeters, 3 centimeters. So how what you say correct is that method?
Yes, actually, that is the right one because in initial gliomas, no, you treat and then you definitely consider a larger margin compared to other tumors. So definitely but when it comes to re-radiation, all the more we are constrained in giving it to a very small area. So that is what I said. If it is a large volume, then definitely we need to make the patient understand that it's only a palliative intent and we're going to palliate the symptoms or to whatever benefit we're going to do. Because we are at a risk of radionecrosis, which is again it's a double-edged sword. So it is definitely we can target only the tumor, and it is definitely not a curative intent, but just to palliate.
Okay.
Dr. Sushil,
Yeah.
my answer to this
Yes.
question would be
Yes.
so when we are treating with conventional fractionation, means 1.8 to 2 gray per fraction versus giving a hypofractionated radiation where we are giving 30 gray in 5 fractions, like 6 gray per fraction, then the dose to the surrounding structures or abscopal effect in the surrounding area is much more. So then when we are giving a high dose, then we don't need to give tighter, we don't need to give larger volumes because as Dr. Karthik rightly said, that the chances of radiation necrosis would be very high. So if we are giving a very high dose per fraction, then the dose spill in the surrounding structures is still high enough to take care of the microscopic disease. But when you are giving a conventional fractionation, say 1.8 to 2 gray per fraction, then the 2 centimeter margin concept holds true. And recently, in the recent ASTRO, a paper has been published by the Sunnybrook group and by Dr. Arjun Sehgal, who has done a lot of work on CNS tumors, where they have specifically taken care of GBM patients and they have treated on MR Linac and they have reduced the margins and they have seen that and they have presented a good number of patient data where they have said that we can safely reduce the margins to 0.5 to 1 centimeter. I'm yet to go through that paper, but it has recently been posted on LinkedIn and on other groups. So I think in the re-radiation setting, the concept of 2 centimeter does not hold true because here we are mainly thinking of about palliating the symptoms and improving the quality of life of the patient. So you cannot worsen the quality of life by giving wider margins as you did in the first time radiation.
Yes.
I had a
Very,
small
very.
doubt
Yeah.
here, if I could have just a half a
Yes.
minute.
Go ahead, doctor.
Actually, it would be to Madam that since we are trying to reduce margins as much as possible, would you be happy to give bevacizumab in these patients with RT, maybe on the basis of reducing the peritumoral edema to reducing the margins? Would that make sense?
I think that's a very excellent question, and I'm glad that you asked it. So, a lot of work has been done on the use of bevacizumab in along with stereotactic radiosurgery treatments because the radiation-induced edema is much more. But there is no data to suggest that you can reduce the margins because you are adding bevacizumab. So there is no evidence in favor of that, but definitely in a re-radiation setting, the radiation-induced edema is going to be much more. So some people have even done this that they have given 1 dose of bevacizumab maybe 2 weeks before giving re-radiation, and then 1 dose after giving re-radiation, rather than giving bevacizumab till progression that we were discussing before. So short course Bev has also been tried in various centers to reduce the risk of radiation-induced edema in a recurrent setting, but I'm not aware of any study where the use of Bev will allow you to reduce your margins. I'm not aware of that.
Yeah, so there is definitely there is no evidence whether bevacizumab will reduce the margins, but definitely evidence is there of re-irradiation with the bevacizumab. As you can see in the systemic review, there is 66% in the risk reduction, and acute toxicity is just 5%. And of course, that is grade 3 or more, and delayed toxicity is 0%. And adding bevacizumab to hypofractionated re-irradiation proved exceptionally safe, and you can see it is also guideline recommended. And concurrent bevacizumab should be considered alongside re-irradiation to decrease the risk of radiation necrosis and other neurotoxicity. Excellent discussion by all the panelists. So now the what is the take home message? The recurrent tumor is not always the tumor we treated initially, hence rebiopsy, or we can consider for the blood based NGS markers. At recurrence, the question is no longer how do we control the tumor, but what are we trying to preserve? The answer is the quality of life. Bevacizumab may not improve the overall survival, but it often meaningfully improves the neurological survival it improves the patient quality of life. The right question is not can we re-irradiate, but who truly benefits. So we need to differentiate. We need to selectively choose upon the patients who really benefits upon the re-irradiation. And in recurrent glioblastoma, the most important endpoint is often not PFS, but progression-free living. So with this, I really thankful to the organizers for organizing the event. I'm really, really thankful to all the panel members. Excellent discussion. I have learned a lot of things. Hopefully, you have also learned a lot of things. I'm also thankful to all the, listeners from across the country. Hope you have taken something with you so that you change your clinical practice in the OPD tomorrow. So with this, I conclude. Thank you.
Uh, Thank you very much, sir.
Thank you, everyone. Thank you, panelists, and thank you, IAIO, for giving us the opportunity. Thank you so much.
Thank you, sir. So, can I conclude?
Yes, please.
So, as we come to an end of this enriching session, I would like to sincerely thank all our distinguished faculty for sharing their valuable insights. I also extend my gratitude to all the participants for joining us today. A special note of gratitude once again to our program director, Dr. Sushil Kumar Yashalla, for his leadership as program director. All the participants will be receiving their certificates within 2 to 3 working days to your registered mail ID. I repeat, all the participants will be receiving their certificates within 2 to 3 working days to your registered mail ID. We look forward to your participation in future IAIO academic initiatives. On behalf of IAIO, thank you once again. Have a great evening ahead. Thank you.